Thank you everyone for joining. And I'd like to introduce my co-host. I'll introduce her a little later, but Rhonda's here with us today. So thank you for being the co-host today.
Thank you so much, Sarah Joy.
Yeah, no problem. So just a quick Zoom reference. So hopefully you all know how Zoom works, but just for anyone who might not remember, make sure that you keep yourself on mute unless you're talking. So we love for you guys to interject and talk. Just if you don't want to say anything, stay on mute so we're not hearing the background noise. Also feel free to use the chat at any time. So that's this icon, this icon right here, and I'll go over a little bit more how that works. And if you are talking, just make sure that you introduce yourself so we know who we're talking to. And then also video, we encourage you to stay on or turn your video on if you're able to. No problem if not, it's not necessary at all. And then the last thing is reactions. So there's this reactions button here. So if you want to give us a thumbs up or clap or anything like that, that's encouraged as well. We love to see those. Yes, thanks, Rhonda. Okay, so the chat. So when you open up the chat, if you click these three dots here, you can choose who you want to chat with. So if you choose host only I will see those messages. So if you have a question you want to ask anonymously, you can send it just to myself and I won't mention your name or anything. Everyone publicly, this means you'll be chatting with everyone. So anything you put in there, everyone will see. And then if you choose everyone publicly and privately, this gives you the option to select another participant to chat with privately. So you could say, hey, I only want to chat with Rhonda, and then send her a private message. Okay, so now our topic for today. So today we're going to be talking about paneling. So paneling is, as I'm sure many of you have heard, is foundational to all of the other elements of the patient's medical home. So that's why we're starting here. And then at the end of our meeting, we'll talk about what future topics might look like. Okay, so what's our agenda today? So we'll start with welcome and introductions. Then we'll go into Wolf sunsetting and CII CPAR updates. So those will be some standing agenda items for all of our meetings. We'll make sure that we update you on both of those every time we meet. Then we'll go into a bit of an intro into paneling. What is paneling? Why is it important? Then we'll have Lacey, and I see that Lacey's joined. So hi, Lacey, thanks for joining. So we're just getting started. And so we have a few slides to go through and then we'll pass it over to you. So we have Lacey here. She's from the McLeod River PCN. And so she'll share her paneling experience there with us. And then we'll do a bit of a Q&A and discussion, and then we'll talk about what future meetings might look like for us. Okay, so first we'll start by introducing your EMR user group leads. So I'm going to welcome Rhonda. So thank you so much, Rhonda. Rhonda is now a co-lead for this EMR user group. So I'm so happy to have someone here with me to help shape these and have discussions with you and help lead this user group. So that's great. And so Rhonda has 6 years of experience with both rural and urban PCN supporting the patient's medical home initiatives. She also has a background in emergency medicine and northern medicine for over 20 years. So tons of experience. So happy to have her help us with these meetings and share her breadth of experience. And then just a quick fun fact. So Rhonda actually grew up in Alaska, and she didn't live in an igloo there, but she did spend a few nights in an igloo just for fun. So I don't know, I can't say I've had that experience. So that's really cool.
You know what? I think it was fun for my mom to just tell me to go with the igloo, really. Thank you so much for that wonderful introduction. Happy to be here. So glad to join. Great to see everybody back after the summer. Just really excited. So Sarah Joy is an analyst with AMA ACT. She's been there for almost 4 years, right? Mm-hmm. Coming into the 4th year there. That's great. And, you know, she has been filling her cup for the last 18 months with more education, lifelong learning, and also kind of exploring the different exercising platforms and apps so that she can stay fit and healthy in her own home. So she has taught me a lot about what is out there. So yeah, great. Thank you so much, Sarah Joy, and everybody.
Thanks, Rhonda. Wonderful. Okay, so now we're going to go into a bit of an annotate activity because we want to hear from you guys and find out where you're from. So in order to find the annotate button, there's this button here, and I'm not sure if it looks the same on everyone's screens. So if you're having trouble finding this, please let us know. We'll try to help you out. But what you want to do is click on this button, and then you'll get a second panel pop up. And on this panel, you want to click stamp here and then select the stamp that you want. So there's a few to choose from. And then once you've selected your stamp, on the next screen, pull something up and then you can put your stamp on there. It's totally anonymous. We won't know whose stamp is whose, but it'll give us an idea, and you'll see what the next slide is in a little bit. So I'll give you a little bit of time to find that just to make sure that you're all ready. And I see Tara's already found one. Oh, and I'm sorry, I guess they're not anonymous. So there you go. Which it doesn't really matter. We're not going to find out anything embarrassing about you.
Love it. Love it.
Perfect. Yeah, keep practicing with those. And I should actually make sure that we can erase those as well. Okay, yes, we can. Yeah, perfect. Okay, so we're going to go to the next screen. So here's the map of Alberta. And so we just want to know where you're from. And just so you know, the cities might not be quite accurate on this map, but do your best to figure out where you belong.
Oh, I love this. And, you know, this is just the perfect map. So cute.
Yeah, it was hard to find one that was kind of fun, not just all lines and names of cities.
Yeah.
Awesome. So it looks like we have a few from Edmonton. We have Fort McMurray. We have, is that Canmore?
Looks like Banff, Lake Louise. Yeah.
Yeah, around there.
Lethbridge. Oh, love Lethbridge. I bet the colors there are phenomenal right now. Oh my goodness. Cochrane, there we go. Yeah.
Yeah. From around the Camrose, Bakerville area.
Oh, Bow Valley, PCN and Canmore. Hello. A little bit jealous. Hello, hello.
Do we have someone from Saskatchewan? Is that what that is there? We might. We do get some out of province people. Yeah. So
Okotoks. Very nice. Bakerville. Oh, wow. That is so great. And we have, it looks like 26 people on the call today too, Sarah Joy. So that's really good.
Oh, that's great. Wonderful. So anyone who's joined newly, we're just using the annotate feature in Zoom to put where we're from on this map here. So if you have trouble finding the annotate button, it should be, you might have a view option. And if you click view, you might be able to pick annotate from there, or you might already have the annotate button on your panel. You can also just put it in the chat if you're having issues finding the annotate feature.
We got Calgary and Edmonton. Yeah. I like when there's an obscure heart somewhere with no city. I like that one. So there's one between Westlock and Grand Prairie. And I'm wondering, is it Edson or where is that there?
Yeah, that's a good question. I know we have people from all over the place.
That's me.
Oh, that is you.
Yeah.
Oh, awesome.
I'm in Whitecourt.
Yeah.
Perfect.
Which I feel like Whitecourt's probably a little more west or north than what the map says, but
yeah. It's hard to tell.
Yeah.
Lacey, what image would you have put on this map if you could for Whitecourt?
Well, our sign does say it's the snowmobiling capital of the world, but probably like a river or a bridge, because we do have two major rivers that kind of join and meet here, and that's our PCN's logo where the rivers meet.
Oh,
that's
nice.
Very cool.
And our PCN is called McLeod River, so probably something like that.
Oh, that makes sense now. Yeah.
Perfect.
Okay, awesome. Thank you, everyone. So we'll move to the next slide now, and I'll clear all of this too. Okay, perfect. So now we'll go into our standing agenda items. So we'll start with wolf sunsetting updates. So some of you may have already heard, but Dean Wheatley, who was here presenting a few meetings ago, so he was the general manager for the Western and Atlantic regions for TELUS. So he's unfortunately no longer with TELUS. But I did reach out to TELUS to see who we should contact if anyone has questions about CHR and getting a demo for that. So the email that they gave us was healthsales@telus.com. And so what I'll do is pop that into the chat here just so it's in there for you guys to copy.
For you.
Oh,
Yep.
Thank you so much. Perfect.
No
Oh, wonderful.
Mm-hmm.
And if you do have an urgent request, you can also just email myself. My email's there too. And so I don't know, Rhonda, if you can just throw my email in there as well, that'd be awesome. Thank you.
Mm-hmm.
So if you email me, I can escalate your request up with their sales team. And so when you email them, they'll assign a case manager to you, and that case manager will work with you to set up a demo or answer any other questions that you might have. And then the other update is about TELUS, the collaborative health record. And some of you might have heard about Input Health as well. So Input Health is actually the company that created the collaborative health record, or CHR. So it used to be called Input Health CHR, but now that TELUS owns the EMR, it's now called TELUS CHR. So that might be confusing for some people, but just so you all know, that's where Input Health you might hear about that sometimes. So the update there is a multi-stakeholder group. And so this group is made up of AMA, AHS, AH, and TELUS representatives. And what they're doing is they're working together to ensure that CHR is integrated with the requirements needed to be live in Alberta. So in order for an EMR to actually be live in Alberta, they have to meet certain integration requirements. And so that's what that group is working on. So that includes billing, patient's medical home, CII CPAR, e-delivery, and a number of other things. And what we'll do is, as this group's work progresses, we'll update you on anything of note that we think would be important for you to know. Okay, and then the last wolf sunsetting update is there's a new AMA resource, and it's called the EMR Integration Table. And I think, Rhonda, you've already found this helpful.
Mm-hmm.
Yeah, and so it lists all of the, oh, I see a heart. Thank you, Charlotte. Yes, it's a very helpful resource, and they do try to keep it as updated as possible. But it does list the top EMRs used in Alberta, and it says whether they're either fully conformed, partially conformed, or on their way to being conformed for each of the e-delivery. So that includes labs and DI, as well as CII CPAR. So if you're considering which EMRs to move to after, or which EMR to go to after wolf sunsets, this can be helpful with your decision. Oh, and thank you, Rhonda. Yes, the address to that is in the chat now.
Sorry, I think the second one's a little bit better. There was a...
Oh, awesome. Thank you. Okay, so any questions before we move on about wolf sunsetting? Okay, and if you do come up with questions, throw them in the chat. We'll address them. Okay, so now a quick update on CII CPAR. So Michaela, what is the official sunsetting date? So it's December 2023 is what the latest date is.
December,
yeah, no
sorry?
2023, yeah. So about 2 years from now. Yeah. Okay, so this graph shows the progress in terms of CII CPAR participation. And so it's broken down by EMR. So we have HealthQuest on the first bar here, then Accuro, MedAccess, PS Suite, and then Wolf. So this shows you that for Wolf, we have 68 clinics participating in CII CPAR, and there are still 358 clinics that could be participating. So that's our progress to date. So we have quite a few clinics participating, but we could have quite a few more participating. And so this data is provincial, but would you guys find it interesting to see it broken down by zones as well? So for example, if you're in Calgary, you can see, well, how's the Calgary zone doing, or Edmonton zone, or would that be helpful? You can just either do a thumbs up or say yes in the chat. And I can't see all the thumbs up, so
Yeah, I'm hearing some yes pleases, and I'm seeing some nods. So
perfect. Sounds good. Yes, we will definitely do that for the next time. Awesome. And if there's anything else that you're interested in terms of CII CPAR updates, just send a quick email and I'll make sure that we add those to the next meetings. Okay, any questions about CII CPAR participation? After this, we'll get into an introduction of paneling. So ask your questions if you have them now. Okay, perfect. I don't see any, so we'll move on to a quick introduction of paneling. So first, we're going to start with, have any of you ever had a role related to paneling? And if you're unsure, you probably haven't, but if you know that you have, quickly throw what role it was into the chat. And I've included some examples here of different roles that you might have heard of that are related to paneling. There are others though, so feel free to throw those into the chat. I don't see any. Maybe no one's had.
I don't see any either. I'm trying to see, does anybody work in a technician in there?
Yeah, actually, POET is proactive office encounter technician.
There
so
we go. Yeah.
Yes. Oh yeah. Okay, I'm seeing some now. Perfect. So Plexetis.
Patient identification, health information coordinator, patient coordinator, panel management assistant. Yeah.
Perfect. So lots. Awesome. So we have some experience in the group. That's great. Yeah. And you're right. MOAs are definitely, they're a key part in paneling. Absolutely. I mean, technically every role in the clinic, right, should be included in paneling. So that's a great point there, Tracy. Okay, perfect. So now let's talk a little bit about what paneling is and why it's important to advancing the patient's medical home. So we see here that paneling comes in at the third pillar of the patient's medical home. So that means that before we get to paneling, we want to ensure that we have engaged leadership and that we have the capacity to improve. So once we have those in place, then we can get to paneling. And as we can see, paneling is foundational to all of these other steps up here. So that's why paneling is so important, right? Because we want to make sure we have our paneling processes in place, we're maintaining those, and then we can actually start working on all of these other pieces to build our patient's medical home. Okay, so what is paneling? So is anyone brave enough to read this on this slide? This is a definition of paneling. And we're not going to ask you any weird questions afterwards. You literally just have to read what's on the slide.
Hi, it's Claire here. I can read if you want.
Awesome. Thank you, Claire. Yes, go ahead.
So panel continuity. Each of our patients is attached to a physician and the patient and physician have confirmed it. The patient record always accurately shows this attachment.
Perfect. Yeah. So essentially what we're saying is it's a two-way street. So we're saying the patient says, yes, this is my family physician. And the physician agrees, yes, this is my patient. And then once that agreement occurs, that's recorded in the EMR. And I think that Lacey might talk a little bit more about this when she presents, but that's essentially paneling, is ensuring that you have that agreement recorded in the EMR. Okay, and why is paneling important? So paneling is an important step towards achieving relational continuity. And what's relational continuity? So relational continuity is when a patient's care is continuously followed by a single provider. And there is a growing body of evidence that shows that having a patient's care continuously followed by a single provider is associated with improved outcomes and satisfaction. So if you want to find out more about the specific benefits to relational continuity, you can go to our website, to the panel and continuity resources page. And there you'll find there's this value of continuity infographic and summary. And so there it lists all of the articles and it summarizes all of the benefits in this nice little infographic here.
I was going to tell you, Sarah Joy, I was at a clinic and they took this and they cut out those little hexagons there and they laminated them and they put them up in their washrooms, because part of paneling and continuity that we're talking about is the patient has a relationship to the physician. And so it's showing them why it's important to who is your family physician is always going to be asked and why it's important. So I thought that was great.
Yeah, that's a great idea. I love that, because that's something we talk about all the time, right? Is that patient education piece sometimes is missing. So yeah, that's awesome. And hey, if anyone wants to steal that idea, go for it, because that's a great idea.
Steal.
Yes, good. Okay, and then just about benefits again. So we have Dr. Richard Lornchuk. So he is the Senior Medical Director of Primary Healthcare at AHS. And so he further emphasizes the importance of relational continuity. And he explains that as a healthcare system, the most important thing we can do is to provide our patients with access to a consistent family doctor. So to say that's the most important thing that our healthcare system can do, that's huge. So that really emphasizes that paneling is key, right, to improved patient care. Okay, and let's take a look at our panel progress in the province. So unfortunately, we don't have 2019 and 2020 data. That's partially due to COVID. So hopefully we can get that data at some point. But the point of this slide is just to show you where we started out in 2015 and how we have been progressing over the years. So we've been slowly improving. And in 2018, we were at 71% of PCN physicians across the province who were either actively working on their panel or who had an established panel. So that's actually quite a large percentage. And it'll be interesting to see how COVID might have affected that. But most of that work was actually because of people like you guys, which is why we're learning it here today, right? Because people like you, change agents, actually play a key part in improving paneling across the province and helping physicians actually do this work. And Lacey will actually talk more about that in her presentation. Okay, and I'm actually just looking at the time. So I think we're going to skip this next activity. And what we're going to do is actually go straight into Lacey's presentation. So Rhonda, I'll let you introduce Lacey.
Oh my goodness, we have such a treat today. I'm so excited. Lacey Smool is with us. Registered Nurse Accelerated Program, completed in 2006. As though that wasn't enough, it just kept going. Began work with McLeod, PCN 2012, Practice Facilitator Training 2015. Then threw in a little bit of Certified Tobacco Educator 2017, great work. And then while we were all just trying to survive, she's completing a bachelor's in nursing in 2020. So Lacey, just amazing work. So happy to have you here today. Take it away.
Thanks so much for the intro, Rhonda. I know it kind of sounds exhausting when you put it all in a list, but you know, the things you do to keep yourself kind of occupied during COVID. When I was asked by Sarah Joy to kind of present on panel management, it's kind of a big task to break down. And when we're adding, providing support to PFs across the zone, we're like, where do I start? I'm not the only one doing this. There's other people involved. How do I set my goals? And it seems like such a big elephant in the room, because you're like, how do I eat this? How do I start breaking it down? Okay, great. I know it's like super important. It affects all my outcomes, and it's the foundational for a patient medical home. Okay, so I know it's important, but how do I even start doing this? And engagement is always the key part, but as that grows and as that trust grows, your physician engagement and as your physician champions come out, there's a lot of work that you can even do behind the scenes. as Dr. Joseph would always say, start with the end in mind. What do we want to, where do we want to go? What's important to us? And how are we going to get there? And if we start with those kind of three things in mind, we can kind of work backwards and set the foundation. So keeping that in mind, that's where I kind of grabbed the topics for panel management. So you can see 1, clinical processes. So that's going to include how I book a patient, what demographics I confirm, my verification process. We'll touch on all of those later. That's going to be about how our clinic process and when we see a patient opportunistically, like when they come into our clinic, how that impacts our panel management, foundational work. Okay. Number 2 is outreach management. These are for patients, any outreach, whether it's email, letter, phone calls, anything that we do where we pull a list of registered patients and we reach out to them. And then our 3rd level is CPAR. So whether you're live with CPAR or not, you might not have this component, but it's using your conflict attachment registries and creating a format where when you resolve those conflicts or speak with those patients, you have a place where it's documented, where moving forward, those conflicts hopefully never exist again. We're able to resolve them. There's always going to be those instances where, you know, one clinic has confirmed with the patient and another clinic has confirmed and the patient still continues to see both physicians. Those are going to exist. We hope that those number of patients gets less and less. And that's really our key indicator that more patient education needs to be done. Actually, funny, both Sarah Joy and Rhonda, we had the same infographic because it's so foundational. And even, you know, later on in my infographic will come up, that was a really key part in even creating that knowledge transfer with our front staff. Because, you know, when this first came out, our staff weren't used to saying, you know, I see you've been seeing Dr. Jane, they're listed as your family doctor, and I see you want to book with so-and-so, you know, I have an appointment with your family doctor. Can I interest you in that? And patients weren't always receptive to that kind of feedback or direction or navigation because they're not used to hearing that. But they don't know that it's better for their health outcomes. They're going, you know, they typically will live longer if they see the same physician. If they're less likely to be hospitalized. And if they are hospitalized, their stay is much shorter if they have a family doctor. Then they don't know those types of things. So sometimes that's even enough to do in panel management, and to push that forward is sharing a little bit of that knowledge, because essentially no physician is going to say, nah, you know, that patient quality of care, that's really not as important. When you say, oh, you know, I could run this in the background, we could improve these processes and work we're already doing, just tweaking them a little bit. And these are the kind of outcomes you might see. And that will help that engagement piece. But we're going to go over a lot of things that you can go through before, if you don't have that engagement piece entirely right now. Okay, just gonna actually start this. Great. So where do we start? How do we start? Like I said, this does always seem kind of like the elephant in the room on how do we begin this. When I'm providing support for NEPF, it's okay. Are we looking at, do you have good enough engagement or like a clinic manager or MOA staff to do opportunistic, meaning so when the patient is in front of you, what's that kind of look like? If you don't have a process in place when that patient is booked and you're confirming demographics, can you talk about that? That's a good starter. Usually you can get a lot of quick results with that. Ours was, you know, whenever I go to do a recall, I have to play Inspector Gadget trying to find a phone number. I have to look to Netcare. I have to, you know, sometimes we were calling up to the hospital. Our simple recalls were taking twice as long, 3 times as long as they should be. So that was a quick win that we could feed off of. We say, hey, you know, if we confirm our phone numbers, we won't have to do that anymore. Is it looking at, hey, and these are all ideas. You can pick one, you can pick all of them, you can just work through them. Whatever you feel comfortable with or whatever you have the capacity or time for is kind of the other thing. Is the physician that always is saying, hey, my TNA is always 22. What's happening? What is some, you know, how do I increase my access? Or if they're not asking those questions and it's just their clinic staff saying, your TNA is 22. How do we change that? Maybe it's looking at their ideal panel size. What's their access look like? What should it be? should we maybe look at the type of patients that we could, if maybe transfer or that would be willing to transfer to a physician that isn't maybe as full in your clinic. So what that might be, okay, there's patients on your panel that you haven't seen or you've only seen once in the last 3 years. Those patients probably aren't that strongly attached. Maybe they could, if they were offered and navigated, maybe they could see another physician in that time. Whatever is important to the physician and however you breach that engagement, there's going to be certain things that are more important to each physician. And sometimes if you can kind of learn what is important to them, you can navigate how you have those conversations. Those who haven't been seen in the clinic in the past year, this is a good way where to start. Can you agree on what type of patients that you want to move to an inactive list? Not that they ever leave your EMR. I know there's just some people that just think that they're gone into the abyss and they're deleted. Those charts always exist. They can always be reactivated. When you deactivate them and that patient calls up and says, hey, I'd like to book an appointment, the way that they show up in your scheduler comes in as inactive, but you can go in and change that status. And what that could be for your front staff or for whoever has contact with that patient, whether it's in booking or when the patient comes in, is maybe I need to have this conversation about attachment with them. What does that look like? Fortunately, there's a whole bunch of scripting that is available on the ACTT website. Now, it's a nice general template about what that attachment conversation could look like. You can pick out what's going to work for you, what you like, what fits in with your normal dialogue. If it just feels like you're reading off the paper and you don't like that, fine, streamline it, hit the high notes. That could be a good place to start. The only barrier that I've come across with that item is that not all physicians or clinics can agree on what is the time frame for deactivating those patients. So that could be something. You could just set the parameter much wider and say, maybe it could be patients not seen in the last 5 years. Could we agree that if you haven't seen a patient in 5 years, they're not that strongly attached to you? Or can we create a status that we assign those to, like saying patient loosely attached or more than 5-year visits, still able to book with patients. So, if that patient calls, we know that they're still available to book into your panel, into your scheduler, but we've identified them. So we know that we should have a conversation with them. Because sometimes it's not always obvious when the patient calls that they have, when we're looking, do we even look at their last visit? Sometimes not, depends on what EMR you're in, that you can see that. And if you have any questions moving as we kind of go through, feel free to just bump them out. We are going to have a question and answer at the end, which I kind of feel like a lot of good value comes out of that. So I'm just kind of go through all of these things. Anyway, so whatever prerequisite you decide on about assigning patient statuses, a lot of that can be done in the background. They're kind of easier to do. You can do it in bulk. It's not when you're deactivating or setting statuses. That's kind of an easy, kind of quick win. You can say, hey, look, we've organized these panels a little bit more. This all kind of happened in the background, but then what do we do moving forward? Is that a search that I do every month? Is that a search I do every 3 months, 6 months? What does that conversation look like? Yeah. Rhonda was just saying, consider using the test patient in your EMR to demonstrate how inactive works and that they will always remain. Absolutely. Also important to note, if you inactivate a patient, it also cleans up your practice reporting or whatever your practice search is, whatever it's called in your EMR. So it will affect, depending on how you report your screening or any other reports that you actively use. It'll be a lot cleaner data. So you'll be pulling the patients that you are most responsible for, that are most appropriate to be in that data set. Okay, and yeah, for the opportunistic, the last one was update the booking process, right? Whoever has first contact with the patient, do they know about booking? Lots of your EMRs will also have that verification button. That's where you can pick validate, verification, whichever it is, and then you can pull that data or that percentage, whichever you prefer, and report on it. Typically, most clinics will say, we're doing a great job. This was us. This was us 100%. We switched from Genoki to Wolf. We were in Wolf for 2 or 3 years. And I'm like, Sue, it's okay. We're doing this good. No problem. Pulled the verification rate. It was 36% or something ridiculous. And I was like, oh, just kidding. So we had to revamp all our processes. The work was being done, but not 100% and not with the first points of contact. So then our goal, typical goals are over 80% for this rate, which means that you'll spend the least amount of your time playing Inspector Gadget trying to reach them. Okay, so that's one umbrella, that's one algorithm where to start. That's opportunistic processes. Okay, next process would be outreach processes. Is there a way that I can pull a search currently? Maybe if I don't want to deactivate, maybe if I want to pull a search to say, okay, people who haven't been seen here in 10 years, can I start here? Is every physician or clinic manager, are they comfortable me just starting here? And that would be something I would breach if there was low engagement. If you were just starting, you hadn't really done much clinic improvement, and they didn't really know where they wanted to go or any type of goal setting, where they wanted to be and how they seen their practice moving forward. I'd say, hey, can we just clean up this? Did you know that there was actually 10% of your patient that fell into this that you hadn't seen for 10 years? And that out of those 10%, 90% of them had moved on to their practice, but you were still reporting on them. Did you know something? Try to pick a tidbit that will help spur that next engagement. And you say, oh, typically they don't know what they don't know, unless you bring it to the forefront. And I usually like to attach a data set to it, because you can say a projection or an assumption, but when you back it up with how much of a data or how big of a problem is it, then it really kind of seems to sail that ship home. So you can use your EMR. The outreach process will also include if you're active and live with CPAR. With those attachment conflicts, even demographic conflicts, if your physicians aren't on board, you contacting the patients to confirm attachment. Hey, can I resolve their demographics? During that conversation, because it's it's all part of the validation. Who's your family doctor? Who do you consider it? Now, where do you put that conversations in a place where everybody can see it, so that you're not doing double the work? Anyway, it's always an important thing too, is to think about the documentation part. Now, I did put a summary of all the tools to kind of get you started. There's a link at the end that has, or a slide at the end that has all of the links to all of the tools. You don't have to do each and every one of these. These are just looking at what I could do, which are kind of fast wins, foundational pieces of start, things that you can do. Some of them you can do with very, little engagement, or some that you can do if you have quite a lot of engagement. And I like to capture these two questions here on the right. What is my end goal? How important is panel management to me? And what am I comfortable with? Thinking about these two things the whole time will help guide the work that you're doing, because there's no sense of spending hours and hours doing this if it doesn't align with, either your clinic manager, your physician champions, or what that goal is set up in that clinic, or in your clinic or the clinics that you support. How can you move a little bit of this work forward that will get you a little bit closer to your end goal? If your end goal is real lofty and you want every patient validated and you want every process documented, good, great. There's always lots of work. There's lots of work to do, but this is a place where you can just start off. Once you've started that work and you have processes in place moving forward, great. What do I do with it? Now that your panels are clean, you can pull specific patient registries. And, there's fairly simple ones, as much as pulling all of your diabetic patients. Those are fairly easy. You can work through, the 22 most common diagnostic codes, which all of your physicians should be familiar with. If not, those are also available to you. Lots of resources on the ACTT website. If you're an MOA or a panel manager, lots of this can be done in the background. You can pull, like the patient or the people that are booking, if they're confirming demographics and they're confirming attachment, that's a big part of the battle for sure. That's laying that strong foundation so that your panel manager or practice manager, all of your roles in the different descriptions You can pull patients that are maybe digging a little bit deeper than just my diabetic patients. Can I pick my diabetic patients that maybe haven't been seen in the last 2 years and have an A1C over 9? Maybe that's something I'm interested in. For us, it was looking at, maybe patients that were seen in emergency most often, and what for, and dividing that down. And then you can really start looking at why is this happening? Okay, I see who they are. What else is interesting about them? How can I add support to this vulnerable population? How can I pick those vulnerable populations out of my practice? So either, I can outreach to them. Maybe they need, a referral that I'm not thinking of, or maybe they're always coming in and there's something in crisis mode. So I'm not digging that extra little bit because I'm putting out a big fire. Maybe it's the people that I never see. And when I do, I'm just worried about catching them up on screening, but maybe it's, it's something else going on that I'm catching them up on screening, but they have had 20 outpatient or emergency visits in the last 12 months. That's probably something that I would normally think about. Okay, so this is where we build off of. This is an infographic. You're going to see this everywhere. This is the big bang for your buck. Oh, sorry. New to slideshow. This, like I said, was not just important for patients to know. It's so important for patients, but it's also so important for staff. When you think about, new turnovers, or have they been with you? Have your staff been with you long? If you're going to change their process, I find such improved take up if they know the why behind it. They don't know that 80% of studies show an improvement in preventative care with greater continuity. No, that's not common knowledge. So I know that has really been the key. And even as I, tailor, because I do a lot of these attachment verifications as well. If there's ever any pushback, like I like in the verbiage and the scripting that's online, that a patient has just as much just as great an ability to say, no, thank you, I wouldn't like to talk about this at this time, as they do to say, yes, in fact, so Dr. Blue is my family doctor. I like to always facilitate those questions so that there's no judgment, because all that, if there is any pressure to pick a path, I find that you don't have that organic conversation of why there might be a barrier. They get maybe caught up in that there is a barrier, but they're less likely to tell you about it. And maybe if there is one, can we talk about it? Can we just create a space to have the conversation about attachment? Oh, you're worried about being able to see your family doctor. That's a good concern. Do you think that if you're attached to somebody, you can only see them? Let's talk about that. So as you do your scripting kind of thing, keep that in mind. And the more conversations you have, and luckily there'll probably be a lot of conflict attachments, you'll get lots of practice. Just keep that in mind, how what you're saying impacts them. Yeah, you can see this is what a clean practice will do, or a clean panel will do for your practice, being able to pull those specific patient registries. Here is the link to some of those tools. So the value of having a panel, that infographic, the calculating your ideal panel size. This is kind of a fun activity if you have a quality improvement team. They can look at what is access, what is supply, what is demand, how does it impact my world. When your physician goes on holidays and you come back and you have chaos, 24 hours, 48 hours, 72 hours, whatever it is, do you want to avoid that? Can we talk about panel size, and can we talk about TNA, and maybe setting up something that can be done while those in proactiveness when that patient or when that physician returns? You'll always find a buy-in. There's always a crack. You just gotta find it. Also, all those tools are available on the ACTT website as well. Okay, so that's it in a nutshell. I know I want to be very conscientious of time, and also I want to leave enough time to have an active conversation if that exists. If you have concerns, if you have certain circumstances or specific instances that come up that you have questions about panel management, it is kind of a complex task to break down, and it's easy to get overwhelmed in what you should, what you think you should be doing or laying that foundation, but it's definitely a work in progress, right? It's what steps can I take moving forward? What is one step I can take moving forward? Okay, I did it for a month. It's not too bad. Wonderful. Can I pick one more? This is a way that you can kind of break it down and see what could functionally fit into either your time, your practice, or, you know, given your engagement.
Absolutely. Thank you so much, Lacey. And there is in the chat the link to the ACTT website where you can find all of those tools and resources. So yeah, go there and peruse. There's a ton on there. So yeah, any questions from people? I know that was really quick. I wish we had so much more time because it's, yeah, an hour is so short to talk about this. But if you have any questions, please, this is the time.
Great presentation, Lacey. Really, really good. Yeah, it's always, what is the, you know, the pebble in your shoe, right? So, oh, yeah. Laura has a question. Perfect. Do you want to come off mute?
Oh, hi. Sorry, I was actually just clapping for the great presentation and how detailed you went, and just like all your information is awesome. Thank you. But
thanks,
no
Laura.
Questions.
And actually, Lacey, is it possible to share the slides with the group just to post on our, like it wouldn't, we have a private network page that we could.
Sure, I'll send them to you, Sarah Joy. And then of course, also if you have any questions or anything, I'll just put my email in the chat. Feel free to reach out, because I know sometimes it's, you know, you're digesting and then you go to application, you're like, oh, well, what could I do about this? Reach out at any time.
Thank you, Lacey. That's awesome.
Yeah, that's great. And I mean, if we think back to the patient medical home and we're looking at making sure that we have that, you know, engagement part, I mean, that is so key. And like you said, there's so many different ways to have that conversation. So if you're finding like you feel like it's a unique situation, please reach out to Lacey. She has so many tips and tricks. I think I could talk to you for 3 hours. I'd need coffee just to stay on board with you, because you speak really fast. But yeah, you have some great ideas. I'm so grateful.
Yeah, and I know this was really high level too, so it might be hard to come up with questions because it was probably a lot of information too. So what I'll do is point you to a really helpful resource. So if you're looking for the website and or for the specific page and you just go to our ACT website, if you just Google ACT, you can go to the website. And then if you go to Patients Medical Home here, and under the Panel and Continuity section, go to Panel and Continuity Resources. So that's where you'll find that page. And then when you're on that page, so this is the list of everything, and I couldn't screenshot everything because it's so long. So you'll find tons, but what I wanted to point you to specifically is this panel processes change package here. So the first tool. And this is really helpful because it walks you step by step through all of the steps to achieving paneling, essentially. And it actually links tools to each of those steps. So that might be really helpful if you're a little overwhelmed and you're like, where do I start? So yeah, maybe take a look at once we post Lacey's slides, because there were so many good tips and tricks, and because there's so much to think about. So I'd say look at those slides and then look at this to try to gauge where your team might want to get started.
Yeah, maybe the first step would be who's on your team. You know, who would do this work in your team setting or in your clinic setting. I know, you know, back in the day when we did our PF training, it was like you were in a silo in a clinic and you're like, okay, you're the PF, you do all the panel management. What about the rest of the team, or like who does scanning or referrals or the MOAs? Who's my team? Because we know now that this work is sustainable when it's spread out in all the hands, where it's diversified, so that, you know, if I'm away out of the office, it's such an embedded process that it will keep up moving forward. It's not that silo work anymore.
That's a great point, because yeah, I mean, as PCNs, we haven't been having those collaborative sessions where you can talk as PFs and panel managers and everything to find it out. So if you are on the call today and you think this forum would be beneficial to a colleague, please get them enrolled. We'd love to see them at future meetings too. More questions, the better. We all learn from each other for sure.
Absolutely. And if there's anything specific about paneling, because this was a really big overview, but if there's something specific, like you're like, how do I actually do this in my EMR? Like, where do I confirm patients? We can go over that too. So if you have anything like that you think would be helpful, you can always email me or put it on the discussion board and we can cover it in a future meeting, because if you have that question, likely a lot of other people do. So yeah, just let us know. All right, anything else? And again, you can always reach us outside this meeting. Thank you, Lacey, for sharing your email. That's really nice of you. So yeah, use that, because yeah, it might take some time to process everything and then be like, hold on, what about this and that? So absolutely.
And we're still in a pandemic, right? And we still have COVID. And so if all you can do right now is just that verification rate, then do the verification rate to the very best that you can. And if you need support in that, we're here to give ideas and tips and tricks. So that is just fine to start there. Who are my people?
Yeah, absolutely. Yeah, it's like Lacey said, right? Small steps. You don't have to do it all at once. So yeah, great point, Rhonda. Okay, awesome. So we'll move forward because I don't see any other questions. And if you do come up with questions, throw them in the chat. But we'll talk about future meetings now. So I don't know if you all saw it, but we sent out a survey in August. And so hopefully you all had a chance to fill it out. If you didn't, let me know. I'll send you the link, because we would love all of your feedback, but I'll show you the results so far. So the first question was, how often would you like to have these 1-hour meetings? So it was very, very close, difference of one person between monthly and every 2 months. So Rhonda and I kind of chatted, we're like, what do we do? It's so close. So what we're suggesting, and if you guys have other suggestions, let us know. But what we're thinking is every 2 months, have these longer meetings. So these would be the meetings where we're covering things like ASAP and other PMH initiatives in more detail. And then on the months that we're not having these longer meetings, we could have a 20 to 30 minute update meeting. So we would cover things, or we would cover wolf sunsetting updates at those meetings. And I don't know, Rhonda, if you want to add anything about those.
Yeah, the update would also include CPAR uptake for the wolf clinics, and new resources that have been put out to support if there's migration of data or anything like that. So really just a quick snapshot, pulse check to see how everybody's doing and what needs to be included. And of course, always making that call, who would like to be a guest presenter at our longer meetings? Who has some knowledge they'd love to share? So, and I think you'll talk a bit about that, Sarah Joy, but you don't have to take up 30 minutes. We're not asking for that. If you have a tip or a trick that you wish you would have known about when you first started being in a clinic working with wolf, and it's just a simple thing you just want to share, whether or not people know it, we'd love to see that too. You don't have to take up the whole time, but that's something we thought we could add to those one-off meetings to the 20 to 30 minutes.
Yeah, absolutely. And I know, like, when I was working in clinics, I was always like, well, this seems obvious, but it's not always obvious, right? So if you did find out something that you're like, oh, I wish I knew this before, I'm sure others are in the same boat. So never think that a tip that you have to share is something that's too obvious to share here. So anything's welcome. So how does that sound? You can give like a thumbs up or clap or say something in the chat. Does that work for people?
Seeing thumbs up.
Lots of thumbs up. Okay, perfect. And the other thing too is we'll always record these meetings. So if you can't make it to one, we'll always have it on the website. I'll try to do it by the next day or at least the end of the week. So if you check on the Monday after the meetings, they should be up there, and I'll throw the slides on there too, so you can have all the information. Okay, perfect. And then the next one was, we were interested in which topics you wanted to cover.
Brewery earlier this year.
Oh,
Cat Brewing Company is all
right. Just a reminder to keep yourselves on mute if you can. Thanks. So yeah, we were wondering which topics you would be most interested in covering in the next few meetings. So all of the topics suggested had pretty high levels of interest. And I'm glad we started with paneling. It is second last on here, but it is a good one to start with because it is foundational to the other ones. So we've gotten that out of the way, and we can come back to paneling at any time. This isn't just a one-shot deal. So, but according to this, it looks like preventative screening, access to continuity, and CII-CPAR are top on the list. And preventative screening makes sense just because, yeah, we've heard at previous meetings that that's kind of fallen to the wayside during COVID. So that would definitely be a good topic to cover. So I think, Rhonda, I think that's what we'll do next is preventative screening. Yeah, and so again, volunteers welcome if anyone wants to present. Like Rhonda said, it doesn't have to be, it could be 2 minutes of your experience with preventative screening. So if you have anything to share on that, make sure you email myself, and we'll see how we can incorporate you in the next meeting. So thank you for everyone who filled out this survey. Oh, thank you, Chantel, for coming. Yes, it was wonderful to have you. Okay, and then we did have some additional topic suggestions in the comments. So someone suggested HQCA reports, which is a great suggestion. We'll definitely look at incorporating those as well, because those are really helpful with paneling as well as other initiatives. So that was a great suggestion. Thank you. As well as building templates and forms. Yes, we can definitely cover that in another meeting. So we'll be looking for volunteers for that as well. Someone asked about a wolf sandbox, and I know that came, that was suggested at another meeting. And so what I would suggest for that is, because at the AMA, we can't talk to TELUS about giving PCNs a sandbox. What I would suggest doing is talking to your PCN leadership team and seeing if they can work something out with TELUS. So that could be at a PCN zone level. It could be just at your PCN level, but that would be my suggestion there. And if you do have specific questions about that from your PCN, you can reach out to me. Thank you, Lacey. Thank you so much. Bye. So yeah, reach out to me and I'll have our EMR advisor make suggestions if you do have questions, but that's something that has to be done at the PCN level. CHR, someone talked about practical experience and new EMR integration. So what I can do is I'll reach out to the TELUS team and see if they can do a demo at one of these meetings, because I think that would be of high interest to people. So another really good suggestion. Yeah. And then another one was billing. So WCB billing. So unfortunately, this isn't within our scope just because we're looking specifically at PMH initiatives. So what I can do is go back to our kind of AMA advisory team for these groups and see if that's something we can cover, but it might not be. So stay tuned for that one.
We
yes.
got a good question in the chat here. I don't know if Tara wants to come off and just explain a little bit more what she's looking for. Templates for referring. So I'm guessing referral forms that are smart forms, so that you can actually fill in the fields and things like that. What kind of uptake do you have with that in the Wolf system? Is that your question, Tara?
Yeah, thanks, Rhonda. Just in the past, our PCN has really, we've found it challenging to, I guess, get forms into Wolf, whether that's like requesting it from like the support team or to try and custom build it ourselves. So I am a little bit more out of touch on the day-to-day of clinics, but especially with COVID, but you know, I can think of some of the Wolf clinics I've worked with, and they are still completing forms in paper and scanning them in because it's not available as a smart form.
Yeah, and you're right. So I think the easiest way to get those smart forms in there is if multiple different clinics or zones are using it. I think that's the fastest way. So we can cover that. I would suggest too, if there is a smart form that you want to upload, throw it into the discussion board and see if other people would find it useful, because then you can have a group of people advocating for it to be added. But yes, we can definitely cover more of that in a future meeting?
I can help a little bit with that.
Yeah?
This is the other Tara that's here. I'm the referral coordinator here at our clinic.
Awesome.
And I actually do a lot of creating of forms and upload them onto our TELUS Wolf.
Oh, beautiful.
Oh, wow.
Yeah.
We've
So,
never been able to crack that nut.
if I'll attach my email, and if you want to get in touch with me, the other Tara, feel free to.
Yeah, for sure. That's great. Thank you. And that, I mean, I know we're very, we're kind of coming to the end of our time today, but like we've also been a little bit challenged of like, do we even bother now that they're like moving towards a different system?
I mean, I guess that depends on, because well, how long until you actually change over, right? So, I mean, my doctors, they love their forms because they don't want to write anything out. And so I am constantly adding things. And lots of times I find that a lot of the forms are out of date on there, or they haven't been updated. So I'm having to adjust and find online the actual like up to date forms, and then having to adjust in our system because nothing has been updated in a while. So it's like, yeah, little bits and pieces that, I just kind of work my way through. But yeah, send me an email and we can have a meet together if you want some help with it.
Awesome. Thank you so much, Tara. Well, both Taras. Yeah.
That was Tara collaboration. It was lovely.
Yeah. And that's exactly what this group's about. So that's perfect.
Yeah.
And if you ever think of a question like that outside this group, that's what the discussion boards are for too, right? So we can have the same collaboration outside of these meetings. So yes, and like Rhonda said in the chat, we are past time. So if you do have to run, we totally get it. And thank you so much for joining today. Okay, and so with that, so next webinar, so we will determine some dates and topics hopefully very soon and send out the invites out for those. And so stay tuned for those. And again, if you have any tips or tricks to share or want to present at a future webinar, email myself. My email's on there, and I think it's earlier in the chat there as well. And you're so welcome, Tara and Tracy.
I was just going to say, hint, hint. Let's get a smart form going on, hey?
We could, absolutely. Yeah. So yeah, if any of you want to present, hey, we'll be happy to have you. Okay. And then again, the discussion board. So please post on there. If you do have any troubles accessing the discussion board, or you want to connect anyone else to this group, make sure you email networks@albertadoctors.org. I'll put that in the chat there now. And then we have Shelley and Leanne who can help you out if you have any concerns there. So thank you so much for joining. Thank you for staying over time with us. We're here if you have any more questions, if you want to stay on just a little longer. We'll stay on for a few more minutes. But thank you, everyone, and have an awesome afternoon.
Bye, everybody. Thank you so much.